Hello, my name is Michael Bornstein and I'm actually from the University of Bern in Switzerland. I'm working at the Department of Oral Surgery and Stomatology and I'm the head of the section of Dental Radiology and Stomatology. Today's lecture will be about CBCT imaging, so actually contemporary imaging techniques in implant dentistry, and it will be also a perspective on the 5th ITI Consensus Conference in Bern held in 2013. I hope you will enjoy it and you will take a lot of new things out of that. Thank you very much and enjoy. So, the next 1.5 hours we're going to spend about contemporary imaging techniques. Cone beam CT is the main focus and it's all about implant dentistry. So I hope I will cover most of your expectations in terms of implant dentistry and three-dimensional imaging, and I will also focus on some of the proceedings of the 5th ITI Consensus Conference held last year in May, end of April, actually in Bern, and just recently the proceedings came out. You can actually access them on the ITI net as PDFs, or I think you can purchase also one of the special copies of the iJomi, but it's very thick, it's 350 pages. Maybe it's easier if you look at the topics and then you get those topics that really interest you the most. But it's a really comprehensive, it was a really comprehensive consensus conference with a lot of issues covered really from contemporary radiographic surgical techniques, pros, complications in surgery, pros, and also maintenance. So I think everything was spanned there, and well, we'll see what research is bringing us in 5 years and where we are, but I think for the next couple of years this is maybe one of the important documents that has been produced. So if we talk about radiographic imaging and implant dentistry, we have to ask simply the question, if we want to do something about this single tooth gap and we are thinking about implants, is this radiograph here enough? Is that enough? Will you do surgery here? Do you know which surgical technique you're going to apply by using that, or do you need anything more? If I would have addressed a crowd 20 years ago and would have asked the same question, maybe the answer would have been, yeah, maybe a panoramic. And then we go for the surgery. Because surgical approaches 20 years ago, 30 years ago, were often like, we open up, look what's there, and if it doesn't work, we suture again and say, oh, it's not possible. Which is a way we shouldn't approach surgeries anymore. With the imaging techniques and diagnostic possibilities at hand, we should be able to plan a surgery to go as it is planned, almost 100%. Every deviation in a surgery from plan has to be considered as a complication, actually. It's a complication. When you have to deviate from the plan, it's a complication. Maybe this complication has no adverse effect for the patient, but as a complication it is there. It's similar like when you do a crown and you have maybe a wall that fractures and you have to do something else. It's also a complication. So a deviation from your initial plan is to be regarded as a complication. So doing surgery always is better if you have it according to plan, if you don't have to deal with smooth surgery. No stress for me, no stress for the personnel, no stress for the patient. I think we really looking at this more and more. And that's also the goal of all these tools that we have now at hand for planning surgeries. Okay, what is needed for preoperative dental implant treatment planning? What do you need? Clearly, you need a comprehensive patient history, medical history, maybe also dental history. You assess his periodontal health or pathology or whatever. You do go to initial phase of treatment also. And a thorough clinical examination of the site you want to place the implant. So this is a simple case in terms of there's only one tooth missing. It's maybe more demanding, an advanced case in terms of the site. It's an aesthetic site. Yeah? And it's also maybe not so straightforward because placing an implant and doing a reconstruction here, I think you should also address this lateral here. That's always some basic question you have to look at. You know, I think that the standard of care can be, on one hand, graded upon the economical possibilities. I mean, if you have a patient with restricted budget, you will go just for a restoration here. But if you have no economic restrictions, it's clear that ideally you will have also to address this tooth here aesthetically. Because when you talk about the anterior maxilla, the aesthetics is also a very important outcome measure. You can't just say it's functioning. You can chew. That's for this type of procedure here, for this type of patient, it's a limited outcome measure, function, because aesthetics is very important also for the anterior maxilla. Okay, what do we need additional to that? That's the basic two-dimensional radiographs that we have. You see, that was before treatment. We have an older, in parentheses, an older panoramic. So it had a root fracture. That's why it was extracted. So it's an older trauma case. And you see that this tooth also is endodontically treated, and it has no crown. It's only composite restoration. So is that enough? Is that not enough? What would you need additional information? What kind of information would you need? And why would you need? What would be the justification to go for additional imaging? So these are the simple questions you actually have to address.